Distal tibial plafond are also termed as Pilon fractures. They account 5 to 7% of distal tibial fractures. These are high energy trauma, and the mode of injury is the talus is driven in the plafond, resulting in articular impaction of the distal tibia. As you all know, distal tibia has a poor soft tissue coverage. It's accompanied by serious soft tissue injury. There are tension blisters like the upper end of tibia, what we have seen in the earlier lecture, and that needs a delayed surgical treatment. So the mechanism of injury is either a high energy or a low energy. Low energy is the one in which you have a torsional injuries. There is lesser comminution. Most often these injuries or these distal end tibias have a spiral nature of fracture configuration, and the amount of soft tissue injury is less, as against the high energy which has axial compression, metaphyseal comminution, multiple displaced articular fragments, and a significant soft tissue injury. So two spectrums, a low energy and a high energy, both are different. Low energy can be managed immediately, high energy requires some time. And when we talk about fixation, you have to consider two aspects. The articular surface reduction, and second is a metaphyseal, that is articular alignment to the diaphysis. And both require separate management. One, the articular surface, wherein we do not want any step off, and second, the metaphyseal to diaphysis alignment, where we do not want any axial deviation. The two angles which one must consider while fixing or while analyzing this fracture is a lateral distal tibial angle, which has to be around 89 degrees plus minus 3 degrees, and that gives a valgus or a varus deviation to the foot. The second important angle is an anterior distal tibial angle, wherein that gives a containment of the talus underneath the talar dome. So the talus has to be centered beneath the mechanical axis of the tibia in a sagittal plane to get a good function of the ankle. Now here is a case. So why does the ADTA and the talar station matter is, you can see this is how it has been fixed. It was a bimalleolar fracture, and you can see already there is a significant varus, and the talus is shifted anteriorly. So if you draw the axis here, the ADTA and the talar station, the talus is shifted anteriorly. So this is mal-reduced, the ankle is subluxated, and it is expected that this will have poor results. The investigations what are important are standard X-rays and a CT scan, because it is on the CT scan the missed posterior malleolus or a metaphyseal comminution will be evident, so also the step off, and it also assists in classifying what type of Pilon fracture it is. So it gives additional information in almost 82%, and hence it is must. The surgical plan on a plain X-ray, on a CT, will change in almost 62%. The timing of the CT scan recommended after the fracture has been adequately reduced and stabilizes. So that means in those high energy, we have to span the ankle and then do the CT scan. So the problems in treating this fracture is the timing, management of the soft tissue, what surgical approach you would take, what are the plating techniques one would use, and post-operative soft tissue management and external fixation. The timing is so important, and it has been published long back, almost 2 decades back, that if you are immediately fixing it, the wound complication, skin necrosis and wound dehiscence are almost to the tune of 100% when you have a high energy injury. Now, this chart, as you can see, if you are operating within 4 days, The chances of soft tissue impairment are highest, but as you go down the time, that is around 3 8 days or 12 days, the chances reduce significantly. So in those high energy where the soft tissues are compromised, you have blebs, it is better not to touch them immediately. Give a time of 2 to 4 weeks and then do a delayed surgery wherein your complication rate reduces almost to less than 6%. So till that time you need a spanning external fixator, and in that it has to be a bicolumnar distraction. The medial and the lateral side has to have a controlled distraction so that the talus is reduced underneath the tibial plafond. So bicolumnar distraction and bring down the talus under the tibia so that you don't end up in complication. So this is a common scenario, and this is a stage where one should not touch that ankle. So this is the x-ray of that patient, and if you wait sufficiently where the blister resolve, the edema subside, the ecchymosis disappears, and a wrinkle sign appears, that is a time where the reepithelialization of the fracture blister occurs. It takes about 2 to 3 weeks depending on what type of blisters they are. If they are serous, it is early. If they are hemorrhagic, you have to wait for more than 2 weeks time, and at the end you will get a result wherein the fracture has aligned, there is a good alignment, there is no infection, there is no wound dehiscence, and it has healed perfectly with good range of movement. When we discuss the surgical approach, the two approaches which are most important, one is the anteromedial and second is the anterolateral. The advantage of anterolateral is you can fix the fibula and the tibia as well through that anterolateral approach. The anteromedial approach is the one in which it's a classical approach. We visualize the lateral caput fragment. The risk of implant prominence and wound breakdown is very less. So that is the exposure that one can get. But if you have to go on the lateral side, the anteromedial approach cannot address this area which has a lateral caput fragment. So being subcutaneous, there are no muscles on the medial side, the risk of implant prominence and wound breakdown are little higher. The incision is lateral to the tibial crest and it curves medially to the tibialis tendon. Whenever you are dissecting, whenever you are taking this approach, preserve the paratendon of the tibialis anterior. Don't open the tendon. Otherwise, the fibrosis and subsequent complications are higher. It has to be curved across over the ankle so that you get that much exposure. So lateral to the tibial crest, medial to the tibialis anterior, preserve the paratendon and curve across the ankle so that you get adequate exposure so that you can reduce and fix the articular segment, and then with a MIPO you can connect with a longer plate. The Bowler's approach or the anterolateral approach is the one which is commonly used, wherein it's an extensile approach which gives you access to the entire anterolateral aspect, and your plate will be covered once with the muscles, and it has a improved soft tissue coverage over the implant, and with the same approach you can fix the fibula as well. One more extensile approach which has been described is this one, extensile approach, where you take an incision 1 centimeter lateral to the crest, 1 centimeter below the medial malleolus, and then connect these two incisions. When you are connecting at the angle, change the blade from 24 to 15. At that angle has to be about 110 degrees. So that avoids skiving, that is an oblique cut to the skin, which is very precarious. And you have to do a gentle retraction. Again, the tibialis anterior tendon has to be retracted along with the sheath. So at this junction, one has to be careful not to use a thicker blade or 24 or 25 size blade. Use 11 or 15 number blade whenever you are at the junction. So use those smaller retractors instead of big retractors, and you have to be gentle while retracting the soft tissues. And thick flaps along with the soft tissue have to be raised. So there is nothing on the medial side. You can go directly over the periosteum, and you have the entire exposure of the distal tibia and the plafond. Incising the periosteum, and so that is a fracture. Fibula has been fixed first to get alignment of the tibia, and after having reduced it with temporary K-wire, interfrag screw, then fixing a plate. So that is the exposure what you can get, wherein you can connect you can reduce the articular block, the articular fragments, and connect that to the metaphysis. At wound closure, this is the post-op X-ray. That is his wound healing, and that is his final X-ray at 1 year. So this approach can also be used for treating some subset of these plafond fractures. Anterolateral approach, it allows a visualization in the joint as far as the medial malleolus or the medial shoulder, up to the medial shoulder, but no further. There are two main groups which can be identified. These fractures can be in the first group where there is a coronal fracture, which are usually seen in elderly. These are low energy injuries, and usually they have a valgus angulation. The second one is a sagittal fracture. They occur in a younger individual with a high energy injury, and they have usually a varus angulation. So two groups, one is angulated in valgus, the second group is angulated in varus. Both have a different management. So I'll come to it again. A must-read article is this classification, which was published in JBJS long back, and they describe on a CT scan the amount of fragments what one would expect in a 2D CT axial cut at the tibial pylon. So there are three major fragments. These are the anterolateral caput fragment, which has attached anterior inferior tibiofibular ligament. We have the posterior malleolus or the posterolateral Volkmann fragment, which has an attached posterior inferior tibiofibular ligament, and the medial fragment, which has an attached deltoid ligament. So whenever you are giving a traction, these three major fragments are amenable to a distraction. So rest of the fragments, they are not amenable. So what are the other fragments? These could be the anterior fragment. So these are the three major fragments. What are not amenable, what are not attached to the ligaments, are three more fragments, and these are the anterior fragment, the posterior fragment, and a die punch fragment. So how do you reduce that? I'll come to it. Before that, we have to take a decision whether which surgical approach one should take in this tibial pylon fracture, which implant one must use, whether a medial plate or a lateral plate. So now the difference is, when you are using the first plate, the medial plate, your compression or the buttressing will be in a sagittal plane, that is from medial to lateral. And whenever you are using the second plate, your compression of the articular segment will be in an antero-posterior direction, that is in a coronal plane. So depending on your X-rays, depending on your CT scan, you decide. So apart from this, the most important is, where is your anterior fracture line exiting? If it exits medial to the medial shoulder, prefer an anteromedial approach. Okay. If it exits lateral to the medial shoulder, prefer a anterolateral approach. To make it more simple, if the major fracture line runs in a sagittal plane, usually they are associated with a varus angulation. So the fixation has to be where there is a compression. The fixation should be on the medial side, and your screws will be compressing the distal fragment. So the screws will be perpendicular to the fracture plane, which is in a sagittal plane. So that is how one must take a decision. So medial approach, medial plate, whenever there is a varus angulation. So the implant must counteract the displacement. Put implant where you would put your thumb to reduce these fractures. So another example where you can see this has been followed. Now, when the major fracture line, where you have a valgus angulation, or where you have a major fracture line which is running in a coronal plane, that means you require an anterolateral approach or a lateral approach, and your plate has to be an anterolateral plate. So the plate fixation on the compression or the concave side of the deformity. So valgus injury, anterolateral approach, and a valgus or anterolateral plate. So these are the two principles: surgical approach and how you should plan. How do you reduce the articular segment? It has to be anatomical, and for that a good exposure of that articular block is a must. So visualization and reduction are aided by distraction. You can use a temporary distractor, take a exposure and expose these fragments. Now, what is a reduction strategy? First is you rotate the caput fragment. The anterolateral fragment has to be rotated out so that you can work on the articular block inside on the anterior and the diapunch fragment. Correct the central impaction and fix them with the K-wires to the posterior fragment or the posterolateral fragment. Having done that, then you address the medial main fragment and fix it to this posterolateral fragment. Having done that, then derotate the anterolateral fragment, which is a caput fragment, after having corrected the diapunch, after having elevated it, and then with multiple K-wires, you secure the articular block so that you get a normal articular reduction, which is aided by C-arm, and then you put strategic lag screws depending on how is the configuration of the major fragments. All throughout, you have to use a fixator which will keep the ankle in a distracted position. So here in this diapunch, once you have reduced the articular segments, in the defect you add graft depending on how much is the defect. Fix it with temporary K-wires. So you can see the distractor, how it is being used to distract the joint. So much space has been created so that you can also visualize the fragment in a good talar dome view. A good lateral view is a must. Secure with temporarily with the clamp so that you get a good articular reduction. Now, whether to fix the fibula first, when would you do that? Provided there is no combination in a coronal and a sagittal plane, one should not end up in a deformity like that, because that will be transferred to the tibia and you will have a corresponding deformity. So unless you have a short oblique or a transverse fracture, or you are sure of having corrected the length and the rotation of the fibula in coronal and sagittal plane, do not use the fibular plate first. You can work on the tibia and then complete the fibular fixation. When you have smaller fragments which are not amenable to distraction, like the small posterior fragment or a diapunch fragment, so if you are not able to get a reduction, you can use additional smaller plates to have a good purchase over the screws. Now here you can see on the right hand X-ray, there is an evident gap between the two major anterior and the posterior fragment, and you can see the talus has subluxated anteriorly. That is not what we want. So these smaller fragments which are not amenable to distraction can be directly reduced by smaller mini approaches in addition to a single standalone approach. Joint distraction and reduction of the posterior malleolus can be aided here. The posterior malleolus is not reducible in spite of distraction. So you can use a shank pin to maneuver that and get it in anatomical position to reduce the articular surface. Articular overcompression is also not one should expect or one should desire. Here you can see the two major fragments have been compressed by this anterolateral plate, and that has produced an angulation over the talar dome, abnormal space, and that can result in stiffness and a mismatch between the talar dome and the pilon or the articular surface. So this is over compression of this fragment and has resulted in angulation like that. The articular step, again, like you can see here, even though there is a robust plate, but there is a significant step off, and the result, why? Because the posterior malleolus has not been addressed. So this required a separate posterior approach so that you could have got a good reduction of that posterior malleolus. So this is not amenable to anterior posterior screw through the plate. It requires a separate posterior approach to reduce that. And again, you can see the talus is not stationed underneath the talar dome. It is subluxated. After reduction and provisional fixation, joint fragments are fixed with mini fragments. If mini fragments of hand and foot can also be used for fixing these small articular fragments, so that like the tibial condyle, where you can use a circumferential, or in HOFAs what we have seen earlier, you can use mini screws to fix this to get a good articular alignment. And at the end, one should expect a good alignment, a good no step off, a good stationing of the talus underneath the dome to get a good end result. So the closure, in case if you have difficult, you can use a Donati-Algover sutures to reduce the complication related to the soft tissue. A well-padded dressing, drains for 48 hours, and early range of motion should be started. These fractures should not be allowed to bear weight for at least 12 weeks. So this is to summarize how one should manage tibial pilon fracture, whether it is open or closed. If it is a closed fracture, what type of fracture, type A fracture or type C fracture, what is the surgical approach, how is the skin condition, where you would use the plate. And to conclude, take home messages. Timing of the surgery depends on the severity of the soft tissue injury. Skeletal embolization will facilitate soft tissue healing. Wrinkle sign indicates a safe timing of a surgery in these fractures. Careful evaluation of the X-rays and CT scan are essential for a pre-operative planning. And out of all, the 3D CT and a 2D axial at the level of the articular surface will give you a lot of information on those 6 or 7 fragments which we tend to miss. Selection of a correct approach, whether a medial approach or a lateral approach, will depend on the angulation of the at the metaphysis, and accordingly you'll have to use a plate either on the medial or the lateral side. Understanding the stability of the fragment and the sequence of reduction helps in a good reconstruction of these bad fractures like what we have seen. The articular surfaces require anatomical reduction, that is a direct approach. The proximal fixation can be done by a MIPO technique, but you cannot compromise on a MIPO technique for the articular reduction. Absolute stability is essential for the articular fractures, and early range of movement for articular fracture will decide the amount of stiffness what you will leave behind. So this was in conclusion about these pilon fractures, what one must know, what are the things which will help us, what is the importance of CT scan, and the surgical approaches one must practice to get a good result. Thank you.